can start. That's perfectly fine. No, let me just welcome you all first, especially the chair of the session and the discussant is also there, Dr. Shalini Bharat. Thank you for agreeing to chair the session. You know that you have a busy schedule. Amidst that, you have found time, and actually we are really happy that because you have also a person who has worked in such areas. So we really value your time for chairing this session and welcome to this panel discussion. And Professor Usha Ram will be the discussant. Usha, I don't think I need to really introduce, so I need to tell. So all of us know each other. So Usha, thank you for agreeing to be a discussant and welcome. Let me also welcome all the panelists for agreeing to be part of this interesting panel, which is very appropriate and timely, especially when we are experiencing a second wave now. When IAPS, when situated in Maharashtra, we all feel the heat of the second wave right now, and usually Maharashtra leads and then other states follows. That is the pattern which we have seen. So we may also expect that a second wave may be there in all parts of the other parts of the country as well. So thank you for agreeing, and Shireen, thank you for your being in Maharashtra. You definitely understand. And Soumya, it's nice to meet you virtually after a long period, and thank you for agreeing. And I know it's an odd time for you, but thank you being part of this panel. And Dr. Ravi Verma, again, I don't think we need to really, he's one among us and formerly with us, all of you are formerly with IAPS, so that way we don't need to really introduce ourselves. Thank you, Ravi Verma, being part of the, I know you were traveling last 2 weeks and suddenly you are there in our panel with us. And Dr. Haris Ananda, he is the current president of the Asian Population Association, and formerly with the University of Singapore and currently with the Universities Indonesia. He has been a demographer and working in the areas of economic demography for a long time. And I hope he will be, he has already joined. I hope I see him in the list. For Aris, is it audible to you? Maybe the connection is only just getting. Thank you all for joining, and I think let us, without wasting much of our time, let us start the panel. Let me hand it over to Dr. Shalini Bharat for the rest of the session. So over to you, Dr. Shalini. Shalini, you are muted, I think.
There is a problem of network.
She's not there now.
No,
there is a problem of network.
Sir, she was telling that she was having a backup and it may go at any time. So
but she's
she
there.
Will come back, sir.
She's there. She is visible. Only thing I think connection has some problem.
Yes, sir.
So in that case,
Dr. Iris, is it audible for you?
Yeah, I am new with the WebEx, so I'm trying to find out how to share the PowerPoint.
That maybe at this time it has not been given the right. You will be given the right when you are presenting. So I think each one will be given the right only at that point in time. Only one can be given.
Thank you, James.
Yeah,
but I sent my PowerPoint to Professor Unisa.
Yeah, okay. Yeah, the WebEx is not as convenient as Zoom. I think Zoom is always far better than WebEx, but we are constrained that we can only use WebEx or other one. We are not allowed to use Zoom.
So, no problem.
Dr. Edis, I am there. And I think there is a problem about Professor Shalini Bharat. Professor James, you can start it. She will join if there is any. Her network problem. You can start the session.
Yeah, I think there is some connection issues with her. I think we will resolve it and she can join back. Okay, Professor Shireen, I think the first speaker is Dr. Shireen. Shireen will be speaking on the consequences of pandemic for young people, a synthesis of what we know. As all of you know, Shireen has worked extensively on the youths as well as adolescents, and her major contribution in India on these two aspects is really well known to all of us, and the published publications and reports, etc. Okay, Dr. Shalini, have you joined? Is it audible now? I think there's still some problem with the connection, it appears. Okay, I think over to you, Dr. Shiri. You can perhaps start your presentation and you'll be given the right to share the PowerPoint in case you have a PowerPoint.
I've got
Okay.
it.
Yeah, okay, you can start.
I'm going to switch off my video.
Sure.
Okay.
Once you share, you will get a square.
Yeah,
You have to press the
is that-
square. And
Can you see?
no, it hasn't come yet.
Oh, dear.
Not yet, Shirin.
Oh,
You have to share and then one of the square.
that's what I did. Okay, share. Okay.
Yeah.
Now?
Yeah.
That's
Now
yeah,
it's now it is seen.
Oh, great. Sorry for that. So thank you all very much for this session, for this inviting me, and congratulations to IIPS for a very interesting seminar. I've tried to attend as many sessions as I could. And actually one of the topics I think least discussed at this seminar, and the one I'm going to try and highlight here, is about the consequences of COVID-19 and the prolonged lockdown on adolescents and youth in India. Needless to say, young people may not be, why is this Usha Ram on my screen? Is it, okay, sorry. So as I was saying, needless to say, young people may not be the face of the pandemic, certainly, but the pandemic is having huge effects. It's really exacerbating many of the threats to well-being and exercise of rights that young people already face. And needless to say again, data are particularly sparse. So what I'm doing is providing you a broad scan of what is available from this pandemic in India, from a variety of sources. And I'll try to touch upon what we know globally also, which is a little bit more than what we know for India. Okay, so here are some of the key domains of young people's life that has been affected by the pandemic. I'm not going to read out all of them, but just want to emphasize the breadth of effects that have been documented. And I'm sure there are many that I have not addressed here. I'm not going to dwell on this slide, but just to say that cross-cutting all of these are consequences for gender equity, empowerment, and exercise of rights. So let's start with education. Globally, more than 1.5 billion children and adolescents were out of school as a result of the lockdown. And the shift to online classes has resulted in a range of consequences in India that widen inequities by poverty status, by gender, and even by parental education levels. And these are likely to have an effect on schooling outcomes in the future. So the evidence we have from India confirms this, that poor students and those in remote areas have difficulty in accessing devices. They have difficulty in getting uninterrupted network connection and even electricity. That's been said, and I think it's been said here too. At the same time, we know from many surveys that far more boys than girls own their own devices in general. And given the son preference that prevails, if there's only one device in the household, boys will get preference. And the new online format, moreover, requires a major change in the role of parents. Many lack the digital skills to access and use online opportunities. Many parents lack the required teaching skills. Many lack time. So all these reasons makes one concerned about effects on schooling. School services are, of course, also affected. No midday meal, no school health services, and finally, no interaction with friends or a nurturing school environment, which in itself has consequences for young people's lives. Now, what happens when school reopens? Almost 7 million primary and secondary school students could drop out, according to a a World Bank estimation. Although a more recent UN report has projected that the number could rise to 24 million almost across pre-primary, primary, secondary, and tertiary levels. We know from past epidemics that adolescent girls are at particular risk of dropout and not returning to school even after the crisis is over. And just to say, the 6% drop in allocations to budget 2021-22 will not help. Okay, so moving now to effects on work. I refer to an article by Basule and Abraham that shows that the young were more likely to have lost their jobs during or after lockdown. As you see, 59% compared to fewer in the older ages. And again, females fared much worse than men, and they were twice as likely to lose employment and much less likely to gain employment post-lockdown. So obviously, young women are worst off again. And then when we look at preparation for the school to work transition, what do we see? Globally, the pandemic has also intensified women's unpaid care and domestic workloads far more than boys. In India too, increased workload has been documented, including among young women. More girls than boys report increased domestic responsibilities, and girls spend significantly more hours doing these responsibilities compared to boys. And of course, preparation for the school to work transition also suffers, particularly for girls. In crisis situations, we've seen that whether that many will enter unsafe workplaces prematurely, fewer gain the financial and digital skills needed, or the soft skills enhancement, and even access to opportunities and entitlements. There's a very interesting article by Judith Bruce that talks about these effects. Now, turning now to child marriage, it looks like the gains we made in reducing child marriage will stall or reverse as a result of COVID. UNFPA has estimated that the economic downturn and stalling implementation of programs will result in 13 million more child marriages. And this spike has been seen in previous disasters, in the Ebola crisis, in times of flood and famine, even in India. There's a recent review of the Kosi flood that suggests a spike of some 7% plus in child marriage for both females and males. And we know that child marriage is seen as a coping mechanism to address poverty, one less mouth to feed, lower dowries perhaps during this time, lower marriage expenses, and for boys, any dowry for the household. And to so-called protect girls from the insecurity and maintain the family izzat. So these are all possible effects that we are seeing and that we have seen in small settings. Turning to mental health, there's a fair amount of evidence globally about COVID effects on mental health. A rapid review in The Lancet reported an increase in PTSD symptoms, confusion and anger in the general population. And yesterday, Anandi Shukla reported from a systematic analysis of 21 settings that young girls and young women are particularly at risk of stress and depression. In India, there's also some evidence from studies conducted by the Population Council, from the Population Foundation of India, and by DASRA, that all suggest that feelings of sadness and depression are prevalent among the young and have increased since lockdown was imposed, and even that reports of young people contemplating suicide have increased. We see the whole time articles on student suicide in our newspapers, and that's very devastating. Turning to violence, globally there have been so many reports of spiraling violence against women and girls that UN Women coined the term shadow pandemic for violence. In India too, Ravindran and Shah's analysis of complaints of violence in the general population from data received by the NCW from across the country, it showed that domestic violence complaints and cybercrime increased hugely. And particularly in districts with the strictest lockdown rules, the red districts. But rape and sexual assault for reasons of lockdown had seemed to have decreased. Girls are at particular risk. Evidence from earlier pandemics, for example, the 2014 Ebola crisis in West Africa, showed that girls faced much more violence than they did before. In India too, there's been an increase in calls to helplines and in referrals to youth serving organizations. Sexual and reproductive health. There's very little information on COVID effects for adolescents and youth specifically. So let me start by sharing some global estimates as you see here. Effects are evident on every indicator: maternal mortality, unmet need for contraception, unintended pregnancy, unsafe abortion. The numbers are staggering. So are IPAS's estimates for abortions in India. And then looking at the effects among the young, what do we know? As you see in this slide, what we know also suggests severely compromised access to SRH services. Pregnancy-related and newborn care have not plummeted, but fell during that time. Access to modern contraceptives suffered. Access to menstrual hygiene products and other supplies have also been affected. And all this while frontline workers and adolescent-friendly health clinic counselors are preoccupied by COVID-related work and have even less time to counsel or serve young people or comply with ministry guidelines for providing teleconsultation through AFHCs. So what can we do? I think in short, consequences for the young are huge, likely stalling, if not overturning, the progress made over the recent past in education, in access to healthcare, in empowering women and girls. It's going to widen inequities between the rich and the poor, between boys and girls, and likely have longer lasting effects. I think I'm out of time and I'm not going to belabor this, but just a few points that people have noted and that I think are very promising. Let's empower youth champions. They've shown a lot of resilience and huge initiative during this time. We need to engage community stakeholders and available platforms in a different way. We need to expand information and service delivery models. We need to use digital opportunities that COVID has thrown up. Task sharing and shifting to supporting adolescent mental health and SRH needs to be looked at much more carefully. And finally, a plea for gender disaggregated data that will allow us to monitor and track these events. Thank you. Hope I haven't exceeded by too much. Okay.
Thank you, Shireen, for that wonderful presentation, a synthesis of the existing information and data. We will now move on to Dr. Soumya. I can't see Soumya on the screen. Is Soumya there?
I'm
Hello?
here.
Okay, so Dr. Soumya, over to you. My internet is very patchy at the moment, so I won't lose time, and please go ahead. I'm also going to request all the participants to please put up their questions, if they have any, in the chat box. And then we'll take them up towards the end. Over to you, Soumya.
Right. Thank you, Shalini, for your very kind introduction. And give me a couple of seconds to, are you able to see my screen?
We can only see you at the moment. The screen sharing perhaps is not yet.
Okay.
So
wait.
if you can
Let's
just
try it
click
one
on
more
that.
time. Yes. How about now?
Yeah, yes, that's there.
Okay,
Can
I'm
you
going
do
to make it full screen.
slide
Yes.
presentation?
Yes.
Yeah.
It's good now? Yep.
Yes.
Okay.
Great.
Thank you, Shalini. Good evening, dear colleagues and friends. I'm truly delighted to be presenting today at the seminar hosted by IIPS. Some of you know that my professional journey started at this very institution, and so I'm more than happy to be here with all of you. In particular, I'm also happy that I'm able to be on the same panel as colleagues that I worked with both at IIPS and at the Population Council. So today what I'm going to be talking about is some data that that colleagues of mine, both from our offices in India and in Kenya, have been working on this issue. And so that's what I'll be presenting today about what we are researching and learning in India and in Kenya. And I'll be talking about the different ways the pandemic has changed our lives. Some of the themes that I'll be presenting on have already been touched on by Shireen. And so it's in some ways, it's triangulating our thinking and that we're all coming to the same conclusion. So as per the dashboard on the WHO website, as of Thursday this past week, there were over 121 million COVID cases globally and 2.6 million deaths. And you can see the numbers for India and Kenya, the two countries on which we'll be focusing today. So we've all talked a lot about the scope of the pandemic, the issues around managing and treatment and so forth. But then there are effects that go beyond the health sector. And as per the World Bank's estimate, recent estimate that they put out recently, they say that the GDP per capita has declined by 3.5% last year in the world's poorest countries. And in some countries, what's happened is that it's wiped out the progress that's been made on poverty reduction over the last 3 or 4 years. So in some ways, we're regressed, and there's so much more ground that has to be made up. And then for 2022, for next year, the global growth rate is supposed to moderate at about 3.8%, and with the expectation that economic effects will continue to linger for the next 10 years. So you can see the effects of the pandemic being so far reaching over time as well. In terms of food insecurity, right now, 233 million people are facing food insecurity in 74 countries that are eligible for international development assistance. So the main reason for food insecurity is not only the disruptions in the food markets and disruptions in supply chains, but it's also been due to the lack of income and issues with migrants not being able to send their remittances home. So there are a bunch of different reasons that have caused households not to have sufficient food. And needless to say, these effects that we are seeing are borne by some segments of the population more than others. Oh, I'm not able to move the screen. What happened? Yes, good.
Slow.
So we've certainly learned a lot about the coronavirus itself. We have learned a lot about the disease and its management. But as we begin to see that the effects of this disease are more widespread, and they spread all the way from livelihoods to educational attainment. And in this talk, I'll be talking on the first 5 points that are listed here. I'm not going to be spending time on the health service aspect per se. I'm sure as other speakers have touched upon this. The data that I'll be sharing today are from Kenya and from India. These are not national data, but data of specific geographies. In India, we focused on data from Bihar and UP, and in Kenya from 4 counties in that country. Due to the limitations of being able to do in-person data collection, what data that we have been able to collect is from respondents who are already participating in research studies. And likewise, we were able to survey and talk to these respondents through the phone. And so they're largely phone-based interviews. And the topics that we asked our survey respondents and qualitative interviewees were on the topics that are listed here. And so it's a mix of quantitative and qualitative data that I'll be presenting today. And these data, for all the reasons that we know, because of the difficulties of doing in-person data collection, are not necessary, will have data limitations in terms of who we spoke to, whether there was sample selection and so forth. However, what I want to emphasize here is that they give you an indication from the field of what's really happening on these various topics. So let's begin by looking at what's happening on the livelihood and social protection area. Here, colleagues of mine, they looked at data from Bihar, where they talked to respondents across 794 households. And what they found was that 2/3 of these households reported at least one family member who had lost their job due to COVID. And they all reported that they didn't feel that they had sufficient resources on hand to continue survival in the days to come. So economic distress is fairly prevalent. The good news, if at all, in all of this is that quite a few, excuse me, pardon me for clearing my throat. 88% had heard of at least one social protection scheme, and they had also, and the ones that they listed was the Prime Minister's Jan Dhan Yojana, as well as the free dry ration. And most times they got this information either through social media or from television. We also asked them whether they had received any cash benefits, and over 50% had received cash benefits from at least one social protection scheme, and most of them reported receiving the 500 rupees from the Prime Minister's Jan Dhan Yojana, and about 1/5 received the 1,000 rupee COVID relief funds. And of those who received the COVID relief funds, nearly 100%, about 90 odd percent reported they were able to access those monies once that it was given to them. Now, let's move over to see what's happening in the sphere of mental health. This graph is shows you data from both Bihar and UP. The inner circles refer to responses from male respondents, and the outer circles represent data from female respondents. And as Shireen pointed out earlier, more women than men express some form of mental distress. And the questions in particular that our respondents were asked were they feeling lonely? Did they feel depressed? Did they feel irritable? So these were the sort of markers that the questions that were asked. And we do see that that there's a gender differential in reporting on mental health conditions. Furthermore, even when we tracked this mental health over time, we did a similar survey in 2018, 2019. The questionnaires were not exactly, the question on mental distress was not exactly the same, but we can say that in the post-COVID time, there is a greater reporting on mental distress than prior. Furthermore, some of the women reported experience of violence too. It's about 2% in UP and 5% in Bihar, and we'll come back to this issue of reporting of violence. So yes, we've heard that that respondents are reporting mental distress, but who's likely to feel this mental stress more? It's certainly those who have economic insecurity and are worried about finances, or they're worried about family members who are migrants who have not been able to return home, and women who have experienced violence. The mental health stress, or the stress on mental health, is a layering of different stressors. So once the same individual can experience multiple stresses, and so that will take a toll on their on how they feel, and then the worry and stress that they experience. Now I'm switching over to Kenya, and here we're showing you data from about how adolescents are reporting about their mental health. The data here shows across 4 counties of Nairobi, Wajir, Kilifi, and Kisumu counties. And apart from Wajir County, which seems to be a bit of an outlier, over 80% of our adolescents in our study reported that they felt some degree of mental health. And they also reported that the things that they used to enjoy no longer hold as much pleasure or interest for them. That's the middle set of bars. And the third set of bars talk about how they feel depressed or hopeless. So you'll begin to see that's the same sort of expressions of mental health issues, even across different different geographies. And here again, it's the reasons for why these Kenyan adolescents were reporting their mental health issues. Again, a lot of it was due to family income. Several of them expressed fear about not being able to go to school, and that even if school were to reopen, that they would be unable to re-enroll due to money issues. And for those young girls who had a mistimed pregnancy, there was all these additional fears about stigma and stress. So and clearly, of course, the limited interaction with your peers and friends. So these were all the different factors that seems to have contributed to their mental status. And here's some qualitative data from both adolescents and parents about what's causing and how this mental health uh, status is being expressed. I'm not going to read out the particular uh, quotes, but I leave it to you to get a sense of how they are expressing it in their own words.
So may I
Moving
have
on
2
to,
minutes more?
okay,
2 minutes
I
more?
yes, Shalini.
Sure.
Talking about food insecurity, clearly we are seeing that a lot of households have food shortages. In here, from data from Bihar, there's uh, reductions in food intake. We're seeing a similar situation from Kenya. Over 60% of household heads and over 80% of adolescents say that they have skipped meals or eating less compared to 2 weeks in the last 2 weeks. In terms of violence, here's data from Kenya, and where the adolescents were reporting increased tension and violence at home. And these are the types of violence that they experienced: emotional, physical, and sexual. And there are some reasons for this increase in violence is due to crime, probably due to economic insecurity, conflict, and so forth. Moving on, I think this is the really interesting slide, which is similar to what Shireen was talking about, that even though there was remote learning, we find that remote learning through mobile phones was not really feasible. At the best, it is at about at the 33%. There's certainly a girl-boy divide in terms of access to the phone. So there have been big setbacks to the educational achievement. In summary, what are we seeing? What we are seeing is that the effects are borne differently by different subgroups of the population. There's policy and program action that's required on many fronts. The positive piece of all of this is when we show data of this kind to policymakers and program managers, they have been able to act or have acted on the data and evidence. So I would like to conclude with this slide, which says the timing matters in terms of the call to action. There are immediate things that need to be done, which is around social protection, providing support for mental health, support to keep children in school, and definitely to make sure that people don't go hungry. But in the longer term, we do need to track what's happening to educational achievement when children come back to school, what's happening to labor force participation, as we heard in the earlier panel, what's happening to health outcomes and the disparities in how that health outcomes are the gains or the losses in health are felt. For example, now in the US, where I am, life expectancy has certainly dropped by 1 whole year, and it's dropped more for minority groups than white populations. So looking to the future, the pandemic also gives us an opportunity to build back better, whether it is to improve our data infrastructure and build more better surveillance data, better linking of different sorts of data sets, and the ability of the health system itself to withstand shocks like this. And as touched on earlier, that we need to do research on differential impacts. And I would like to also suggest that we have a coalition of both public and private sector partners so that we have a more coordinated multi-sectoral response. Thank you. And I would also like to thank the various donors and our national partners who part of this, our efforts. And if you want to see more of the publications and briefs that we put out, please look at the link on the last page of this slide. Thank you very much, Shalini, and over to you.
Thank you. That was a very interesting presentation, bringing data from India and Kenya and giving us a very good understanding of what's happening across countries. So it's not really one country. I think it's everywhere globally we are suffering and the ill effects of the pandemic. I'll now move to Dr. Ravi Verma for his presentation. Over to you, Dr. Verma. Hello,
Thanks,
can you hear me?
Thank you so much. Thanks, Shalini. Thank you, everyone from IIPS and colleagues for having me here for this important conference. Just give me a few seconds so that I can share my slides, and then I'll get off from the screen and not use my video. Can you see my slides? No.
Not yet.
Yes, I know, because I've not shared.
Yeah, you can now see.
Now it should be fine.
Yes.
And let me just switch off my video in case I can, which I desperately want.
And please make it a slide presentation mode.
Is this okay?
Yeah, this is good.
Okay. Video camera setting. Okay. I don't know how to switch off the video here.
Stop video. You have to click stop video.
Move your mouse in the middle of the screen on the top.
Okay. Yeah, I can see that. Stop video.
Okay, sir.
Good. Thank you so much. All right. Thank you for wasting a little bit of a time. So thank you again for inviting me to speak in this conference, which is of a great significance, and to be part of this distinguished panel. I'm very happy to be part of a panel which has Shireen and Soumya. It's such a pleasure listening to them. And I look forward to Professor Aris Ananta after a long time. What a privilege. I am taking a slight liberty to deviate from the larger topic or the agenda of the session, which is about the social, psychological, and economic impact of COVID-19. Although I'm sure that my deviation is very well within the paradigm of the impact that we are talking about. I intend to present the experience of a large database on COVID-19 that ICRW and our partners, Global Health 50/50, that you can see on the screen, our colleagues from the Asia, from the Africa Population Health Research Center are collaborating and tracking for the last about 9 to 10 months, and it is still going on. And why I think that this deviation is really not a big deviation, because as Shireen had ended her presentation by saying that we need sex disaggregated data, gender disaggregated data, she said, of course. And we think that all the impacts that we are talking are of intersectional in nature, and gender constitutes the fulcrum of that intersection. This data tracker is a collaboration, as you can see, from 3 different institutions, global. We have a large team from these organizations who are providing the core team. It's not possible to list all the names, but I am presenting this on behalf of this collaborations and represent them on this presentation. But I suppose since the audience for this conference is largely IIPS, I should mention the colleagues working with me from IAPS, Abhishek, Gautam, Kakoli, and Pritha, who have been the integral part of this exercise, and Sneha Sharma, who is our ICRW colleague who has contributed to this mammoth painstaking exercise. What I intend to do is to not really go into the weeds of data, but present some kind of high-level patterns so that I could just use this opportunity as an important or poignant reminder to all of us who are engaged in public health research and on issues of public health concerns, that how serious implications one could have, that's not only confined to health if we do not gather sex disaggregated data. Okay, how do I move to this? Okay. The key objectives of this tracker essentially threefold. As the name suggests, it tracks and creates one of the largest global database of sex disaggregated data on COVID-19. The tracker collates and assesses COVID-19 responses. So there is a policy analysis, policy response analysis, and then we hope to advocate for gender responsive policies to address the gender impact of COVID-19 using this data. So as I said, this is a global effort. We have a team from 3 institutions. There are 11 volunteers, independent volunteers spread across the globe who are recording and involved in data gathering on a regular basis and use multiple data sources. We gather data and collect them from official sources through government websites, dedicated national COVID-19 dashboards, Facebook pages of the governments, the Twitter handles of the government, and so on. So it is a massive digging of the official information available in the public domain from a variety of sources, almost on a daily basis. And then we update the dashboard every 15 days. India-specific data we gather from the Press Information Bureau and through the National Center for Disease Control and CDC dashboard. So here are the core variables on which we gather sex disaggregated data. The number of confirmed cases, number of COVID-19 deaths, and then additional variables on which the data is gathered include testing, hospitalization, institution care, admissions, healthcare worker, infections, and vaccination. In addition to the critical part of the data gathering is to also collect a whole range of intersectional data that include age groups, non-binary identities, sexual identities, social and economic indicators, and in some select countries, we are taking a little deeper dive to gather subnational data. We also gather large contextual information that include countries' income level, life expectancy, population sex ratio, human development index, and gender inequality index. It is to ensure that we have, in the analysis, we could factor in as structural dimensions. So till March 10th, as recent as March 10th, we have covered 192 countries. And this map, which you see now, shows how many countries out of this 192 have ever reported data along the test to outcome pathways. As you can see, there are only 14 countries that are presenting sex disaggregated data on testing, while there are 136 countries that present data on confirmed cases, 11 on the confirmed cases among the healthcare workers, whereas hospitalization data is available for 26 countries by segregation of the sex, and ICU admission in 18 countries. The death data is reported along the lines of sex by 107 countries. Overall, there are 92 countries who have ever reported data on some indicators. The 48 report partial data, and there are 50 countries who have never reported any data. Now, this slide is to give the larger picture of what is the big pattern and interesting. The data reveals some interesting patterns here and perhaps a trend given that we are tracking it over a time. For example, if you look at the slide carefully, while most countries report more women than men being tested, 57 versus 47% countries report more women being tested, proportion of countries is almost equal when it comes to reporting the confirmed cases among men and women. But as we move along on that continuum, we find that more and more countries begin to report more men than women getting hospitalized and admitted into ICUs and even dying. So 107 countries that report sex disaggregated data on death do show that 56% of the countries have more men dying than women. Now, what is the storyline on India? So far, we have 4 states that have reported data on cases, confirmed cases, consistently since the beginning of the epidemic. That is Haryana, Odisha, Tamil Nadu, and Rajasthan. Haryana is the only state that reports on the sex disaggregated data on death. Now, if you look at the confirmed cases in India, this follows slightly different pattern than what we have seen globally. While almost equal number of countries, if you remember, reported equal proportion of men and women among the infected cases, in India, more men are reported to be confirmed, at least in the states where we have been able to track this data than women, except in Karnataka, where there are more women reported to be confirmed cases. The difference in the proportion seems to be to the tune of almost 65% among men versus 35% among women. On vaccination, as of 16th March, we had higher proportion of men who received the vaccination, and I know as drive to saturate the vaccination picks up the intensity, it is hoped that the sex difference would become narrower. But as a matter of a pattern, it is an important reminder of how vaccination uptake must have followed or should be following a gendered pathway, and it's important for us to know and deconstruct that. Now, perhaps it is not a wild guess that whatever differences we see on the later points of the continuum, a lot of that may have to do with the number of cases detected or identified. Now, the global data, if you see, it shows that 41% of the total cases, sex is not known. In India, about 75% of the confirmed cases of those detected COVID-19, which is about 8 million, sex is not reported in official repositories of data. Likewise, for close to 704,000 deaths that constitute about 26% of the cases globally is not known. In case of India, this proportion is almost 98%. So what has been the learning so far? It is evident that the sex disaggregated data reporting is not only incomplete, but inconsistent. We have not had the data on deaths till May 2020 by sex, and after that, the cases after 2020 September on sex disaggregation. Only 4 states have been reporting this kind of a data. And what does this do? A lack of absence of consistent data leads to a weak evidence-based to guide effective and gender-responsive interventions to tackle COVID-19 and its impact that we have heard so far. As a part of this exercise, we also explored as to what could be the challenges in reporting data. And very interesting, we conducted interviews with people responsible for the dashboards and the government officials we talked to. We held some kind of discussions with the government officials in a focused manner. And some of what they share is here. from other countries, and they do provide some insights. For example, if you see Finland dashboard local point person who says that reason is probably resources. This is a matter of capacity. Whereas in England, the dashboard focal point person said the data on sex is certainly recorded, but as it does not appear to be an important risk factor for COVID-19, the dashboard does not have a focus on analysis by sex. Whereas in Taiwan, the correspondence with them in response to our question, they said there is no need to track hospitalization or ICU admissions because everyone in Taiwan has equal access. So finally, what does this project or this kind of exercise do? And I'm sure it must be evident and must be obvious to many here, especially this group. But I must reiterate that this kind of data helps us to first identify the pathways to COVID, to identify and to really recognize that pathways to COVID-19 for men and women are distinct. And those differences that we see will have several underlying causes and context-specific reasons, including gender norms and how these norms are experienced differently by women and men. I have not presented the data here, country-wise differences in the sex differentials in the deaths of cases by the Gender Equality Index or Human Development Index. And that analysis one can see on the website of Global Health 5050. ICRW or WHO has this website, which reveals very interesting pattern that even in a equally high gender equal countries on the index of gender gap index, the patterns of men, the number of men dying compared to women or number of men confirmed cases compared to women are different, and one can only speculate. So so what I'm saying is that pathways to COVID-19 for men and women are distinct, and those differences that we see will have several underlying causes and context-specific reasons. The data on, in fact, as a result, can generate various hypotheses. It is, in fact, a data which provides insights into the inequities in COVID-19 that we have heard just now from our previous speakers. And it stimulates us to think in terms of the role of structural drivers in explaining the differences. And I think more significantly, if these patterns can be replicated, if this kind of data, sex disaggregated data can be replicated for other health parameters, it will be invaluable to show how context and the immediate drivers are critical in not only impacting health outcomes, but several other outcomes that we have heard just now from Shireen and Soumya. And this data can be meaningfully analyzed to frame recommendations for gender responsive policies. We are currently undertaking an intensive policy review and hope that it can support in addressing the issues around access, inequalities in registration system, and it can support eventually in designing gender responsive and equitable policies and responses. Thank you very much.
Thank you, Ravi. That was a very interesting presentation. We talk about, designing and developing gender response solutions and policies, but we need, first of all, disaggregated data, and this global exercise shows us the kind of disparities we still see in data collection and monitoring. So we will have perhaps a few questions. We can already see that on the chat box. We will now go over to Professor R.S. Ananta for his presentation. Over to you, Professor.
Thank you very much. Thank you very much for everybody. Thank you very much for IIPS. I am very honored to be invited to give a talk in this seminar, especially from India. I will talk about Indonesia. Indonesia actually means India island, and there are many similarities between India and Indonesia. May I share my presentation?
Yes, please.
Yes, sir.
There's a share screen button. You can.
Yeah. After that, I start.
Yes, please.
Okay. Okay. Did you see my presentation?
Yeah, we can see your presentation. If you can make it slide mode.
Oh, okay.
Presentation mode. Okay.
Okay, so my topic is in COVID-19 and economy, how Indonesia responded. There are many arguments on the relationship between COVID-19 and economy. One say that whether people should die from COVID-19 or people should die because of being hungry. So there is a trade-off between health and economy. And I will not try to solve the question, but just to show how Indonesia has responded during the crisis. As many other people in the world, we are all shocked. We are all unprepared and we have no knowledge on COVID-19. We did not know what to do. However, now it has been 1 year since the start of the pandemic. Now we know a little bit of the pandemic. This presentation discusses what happened in the first semester of 2020 in Indonesia. Not the current one. I will talk a little bit about the current one, but the data are mostly available now for the first semester of Indonesia. The question is, how did the individual, family, business, and government responded to the crisis? I'm afraid that I will not have time to finish my presentation, so I start with recommendation. Population mobility can be promoted as long as practicing health protocol, introducing cheap, effective, and rapid testing. By rapid testing, then we could screen people who have COVID-19, and availability of cheap, effective, and safe vaccines. Why I talk about population mobility? Because population mobility is very important in spreading the disease, and population mobility is also important in promoting economic growth. Second is that we have to promote use of online technology. And then we will talk online mobility. When we have population mobility, it spread the disease. But with online mobility, we don't spread the disease. I am in Brunei now, but I could talk to you in India and everywhere in the world. And this is what I call as going nowhere, but being everywhere. This is one of the solutions that we can promote to promote economic growth while stopping the spreading of the disease. People should also be prepared with the new emerging norms related to digital technology, including the use of robot and artificial intelligence. This is for the current time and for the future. And the concluding remark is that rising number of infection in Indonesia went together with the rising number of population mobility and economic growth. Some people suffered economically, others enjoyed economically, and some were happy. Online technology have helped raising the household consumption in Indonesia and help improving small and medium scale enterprises. Government expenditure may also have helped raising household consumption too. An application of health protocol among large firms, especially large firms, the application of health protocol has been very good, and this may have helped rising economic growth in Indonesia. So this is the recommendation and concluding remark. Now I'll go to more detail. The data are collected mostly from the Statistic Indonesia, but not necessarily based on probabilistic observation and also based on some personal observation. Because I base on scattered data, caution needs to be exercised in interpreting the connection among these data. And this is the outline of my presentation. I will first present the trend of COVID-19 in Indonesia, which is not sure whether we already achieved the peak of pandemic. Then present population mobility during the pandemic, and then discuss about how individuals responded during early pandemic shutdown 2 March for June 2021, and during relaxation of the shutdown for June 2020, not 21, for June 2021 until now, and how the individual participate in online activities. And then I'll talk about the business behavior during relaxation, about all firms, and about the e-commerce. And then I'll mention the economic growth in Indonesia and concluding remark. This is the trend of daily infection from 2nd of March, the beginning of the pandemic in Indonesia, until 3rd December 2020. If you see from the figure, the green one is a fluctuating. This is the daily number of daily infection in Indonesia, and this is the cumulative one. If you see this, there has been no peak yet until 3rd December 2020. But if I see the number today, the infection reached about 14,000 by the end of the cumulative number of COVID-19 cases reached about 14,000 by 7 March 2021. And the number of daily infection reached 14,000 by the end of 2021, by the end of January 2021. Since then, it's been fluctuating with a declining trend, and it was about 6,800 on 17 March 2021. Some people question whether the testing was already good. If it's already good, then Indonesia reached the peak by the end of January. But even though there are some questions about the testing, I'm cautiously optimistic that this is a real decline. This is about Indonesian population mobility, short-run population mobility, not migration. We talk about Google Mobility Index with baseline in 3 January until 6 February 2020 before the pandemic. I try to, if you could see from the picture, this is the minus, the negative sign shows that there were less mobility compared to the January. When you see home plus, that means there are more activity at home. When you see this yellow one, this is the highest decline compared to the baseline. Minus 19.8, the index is much lower than in January. And in May, minus 55 compared to January. But the negative sign is smaller in June. The lowest decline is among daily needs and shopping. This can be understood because people need to go out for daily shopping. And home, we see that there are all positive, that means that there is increased activity at home. But interestingly, in June, everything, the negative sign becomes smaller, 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 and smaller. And the activity at home, positive, but becomes smaller too. That means during the relaxation of the shutdown, everything had returned almost to the normal before the pandemic. And if you go to Indonesia today, you will see that life seems to be normal in Indonesia. People go out, people go traveling, people enjoy everything outside. There are some people too who are very cautious, but there are some others who don't care about the virus. And the Statistic Indonesia found a positive correlation between Google Mobility Index and economic growth at the provincial level in Indonesia. That means that number of mobility index rose and the economy was improving. At the same time, we know that number of infection is also rising. Government response, there has been a large amount of funding to help the poor and small medium enterprises. Individual responses, we will first talking about early pandemic during shutdown. We will see this. This is the changing condition. We compare early pandemic and before the pandemic. About the job and finance, 60%, 67% said is worsening. In terms of health and communication, say 75.6%, 70 are the same. There are some who are improving their job and finance, do very small. This is the financial welfare during the shutdown, comparison between early pandemic and before the pandemic. The most interesting thing is that there are 97.7% who said that they accept the current condition, and 80% perceive that they are happy family. So even though they suffered financially from the last table, it seems that they are happy. They perceive to be happy. If you see this table, this is about obedience, whether they follow the practice of the health protocol very well or not. This is on the early pandemic. When you see this, that they say that 94.7% wearing masks outside the house. We don't know yet about the quality of wearing, whether they wear it correctly or not. But at least 94.7% say they follow the health procedure. But for the going outside, only for urgent needs, only 76%. Now, about the relaxation of the shutdown. After we have relaxation of the shutdown after June, what happened? During the relaxation, in total, respondent only 70% are working compared to the before pandemic. Without civil servant, it seemed that most civil servant remain working. But if we exclude civil servant, the number of people working is going down to 59.89%. And only a very small number are fired. This is during the after June 2020. Now, during the relaxation of the shutdown, what happened to the obedience to the health protocol? It seems that female is better in following the health protocol, with 94% wearing masks outside the house, but the lowest number is in not shaking the hands. Only 87.2% women not shake their hand, and for male it is worse, only 75%. In the public areas,
Professor Aris,
mask wearing.
30 seconds more.
How many?
30 seconds. Just
30
to keep
seconds.
on time.
Okay. This is the online transaction is going up in Indonesia. Business behavior. This is some of the impact of the business. The worst is on education. This is percentage of firm practicing health protocol. The best one is large firm. The large firm follow the health protocol.
Hello?
The best. Yeah.
Hello.
Yes.
I'm in a webinar. I'll contact you later. Yeah, I'll call you.
Go ahead, sir. Go ahead.
This is the economic growth in Indonesia in 2019. In the fourth quarter, it has been declining. So Indonesian economy was already bad before the start of the pandemic. Quarter 1, 2020, the same thing is worse, and then becoming very bad in the second quarter. But after that, the decline is smaller and smaller again. And then the economic growth was just predicted to reach between 4% and 5% in 2021. So it's very good. So this again, I repeat again, the recommendation to be healthy and having money. Population mobility can be promoted as long as practicing health protocol, introducing cheap, effective, and rapid testing, availability of cheap, effective, and safe vaccine. and use of online technology, online mobility. People should be prepared with new imaging. Concluding remark again, rising number infection in Indonesia went together with rising population mobility and economic growth. It seems that economic growth is achieved at the expense of rising number of infection. Some suffered economically, others enjoy, some were happy. And online technology helped raising household consumption, improving small and medium scale enterprise. Government expenditure may have helped raising the consumption too. And application of health protocol among large firms may have promote economic growth. And the last one is that I want to mention again about the need to stop the number of infection, even though population mobility is growing and economic growth is growing. Thank you very much. I'm sorry I don't have time to present all the numbers. Thank you very much.
Yeah. Thank you, Professor Aris. That was a very good presentation with lots of data coming from Indonesia, giving a country-wide specific data, which is very welcome. I will now invite Dr. Usha Ram to, as the discussant, to give some highlights. And if we have time, we will take in 1 or 2 questions. Participants, to please put up your questions on the chat box. May I now invite Dr. Usha Ram?
Yeah, thank you very much, Shalini. So, for inviting me for the discussant. As all of us know, we have these 4 wonderful speakers who have talked on a range of issues that covers from need for disaggregated data to the effect of COVID pandemic on our adolescent young lives, and Soumya talking about the policy program actions that have been taken in parts of India and in Kenya, and then Dr. Aris talking about Indonesia experience. I did not get the papers in advance, so I hope I'll be able to do justice to what they have presented and synthesize it in a very small way for everyone to reconsider and comment on anything that they may have on these presentations. So if I go over the presentation by Shireen, she talked about 5 key issues that affect adolescents' lives during this pandemic. And I think what was most important, as I noticed, was related to the effect of closure of schools and the switch from the routine schooling to the online schooling that we have, the families have to adopt for their children because of the pandemic. Now this has a lot of consequences for both children as well as for the parents, as she also pointed out. For children especially, to get access to resources in resource constrained societies like ours, whether it is India, whether I'm sure it is Kenya or Indonesia, we know that not every family has access to internet, not every family has access to devices, not every family has access to electricity and so on and so forth. And further, whichever families they have access to these resources, there is always a gender divide when it comes to access to these resources in the families. We typically being patriarchal societies where there is a strong son preferences. In given scenario, it is mostly the girl children who are neglected or who do not get access to these resources. And as a result of this, the effects of this pandemic are much bigger for our young girls and female children than they are for boys and male children really. So that is one important aspect that she has dealt very in detailed way, whatever that she could get data from. And then second important aspect that I thought is very important that relates to issues of mental health among adolescents, and at the same time experiences of domestic violence, which has increased due to pandemic. Now, why it has increased? There are a number of factors probably, but I think one of the most important factors that I would think at a macro level is our social and cultural construct, wherein the girls are often subjected to a lot more regulations than the boys in the families or the men in the families have. Additionally, because of the pandemic, there were a lot of more additional pressures on the girls and the women in general, as they were bounded within the households, and household domestic work responsibilities are, as we know, gendered in nature in these countries. So as a result, they were not only confined in the households or within the families, but also were forced to do, I would say, more domestic chores than they were otherwise doing. And this then hampered their participation in education. So even if there is access to online virtual educational opportunities, A, because of the lack of resources, B, because of the increased responsibilities in domestic sphere, the girl children were marginalized much more than probably male children. And as a result, we see a lot of mental health problems that we have noticed in some of the small scale studies that are available, conducted during pandemic in our societies, and from small setups in rural areas and some urban areas. So that is second aspect. Then third aspect relates to domestic violence, which is mainly because if you look at in some of the urban settings particularly, and especially in the urban poor, there is not much space available to the families to move within the household. And typically these households living in poor urban settings, they accommodate on an average 8 to 10 persons. So now that the men and women are mostly confined within homes and they have nothing else to do outside, economic resources are constrained because many have lost job or their incomes have been marginalized. So as a result of that, there has been shift in drinking habits, especially among men, and that has caused rise or spread in the domestic violence. So these are three important aspects I thought were very important that she highlighted, and we probably can debate them in a lot more detail eventually in the session for question answer session. Then I move on to the presentation by Dr. Soumya, and I would just summarize her work in three key points. First, she talked about how economic crisis has, and as a result of that, reduced remittances have impacted food insecurity and made several households and families vulnerable disproportionately. Because of the economic crisis, many migrants have lost their jobs because most of the migrants, as we know, are in unskilled worker and in contractual jobs. So if they have not been paid because of the crisis, because of the closure of the industrial and entrepreneurs, then they are unable to send the remittances to the families. And in most cases, families whose migrants are sending them the remittances are largely depending on the remittances that they get from the migrant. So if they are unable to send, it has led to a lot of pressures on the families, and it has led to also probably lack of food and other necessities for the families as a result of non-availability of the remittances. That was first aspect that she discussed, and I thought it was very important to. The second aspect she talked about was the mental health problems, how that they have risen among the, particularly among the women that they have surveyed in either Bihar, Uttar Pradesh, or in 4 counties of Kenya, and how the pandemic has aggravated to the mental health concerns of these women particularly. Then the third aspect that she talked about was adolescents education and how that has suffered due to pandemic, similar to the lines that Shirin also spoke about really. So, and then she concluded finally saying that in order to address these concerns, we need to look for a multi-sectoral approach so as to address them in a holistic manner. So that's about Dr. Soumya's presentation. Then I move on to Dr. Ravi Verma's presentation, who walked us through this global project which tracks sex disaggregated data on COVID-19. And some of the key findings that again I think we need to probably discuss a little more in detail is about we know that this is not the problem actually only with the COVID-19. In most cases, we know that we don't realize that the sex disaggregated data is important, just not because you want to learn or you want to create evidence, but also if you want to make programs which are wholesome, which address the population in a ways that they need to be addressed. Unless and until you have the sex disaggregated data, you cannot really come up with any policy solutions which would effectively deal with the issues. So this goes in general, and it is not only in India, but most developing countries that we see in other aspects of life also. The sex disaggregated data has always been a big issue. And what he emphasized here, even in the context of COVID, this is not any new story, to be very honest. We see this everywhere. So as you mentioned that there are 14 countries only which have been reporting sex disaggregated data. I'm not surprised with the number, as I said earlier, but I think we need to take this as an important evidence and maybe advocate about gender disaggregated data at all levels, at all platforms, whether it is international platform or the national platform, to sensitize our policymakers, our programmers, our authors, government authorities, how important sex disaggregated data is and how can this help countries to come up with good policies and programs to effectively deal with the issues. That's a first important lesson that we want to take from his presentation. Second important aspect that he mentioned about was 47 countries never reporting any data on COVID. Again, I would say I can relate that with our civil registration system also. There are many districts in the country which do not report any data on civil registration. So again, this is not a new story, as I say, but we should take these very seriously and try to use them to make our cases more strongly in various forums wherever we go. That's the second part. And then third part, when we talked about how there were only 4 states in India which were reporting on regular basis gender disaggregated data, and how men were more cases of COVID-19 were reported for men. More men got the hospital care, including the intensive care, etc. Again, we probably can look for different indicators to see, because sometimes distribution of the cases may not really give us the real scenario. Maybe prevalence rates could be a better indicator. That's what the way I would probably want to look at it differently. Then you talked about some of the challenges related to the data. And one thing that he talked, and which I really liked, was that when we talk about gender responsive policies, we really cannot do any justice unless and until we have made our case strongly for the gender disaggregated data. And that is something I really like, and I think it's a very strong message that we have derived from his presentation. Now coming to Dr. Ari's topic, and I would apologize to him in advance if I don't do any justice, because I was not able to follow some of the components, but I'll try to summarize as much as possible whatever you presented. So you took us through some of the indicators from the Google COVID index, whatever mobility index and all that. And something that I noticed was that if I look at the response of the Indonesian government to the COVID program, I see a lot more closeness to what we have done the same in India actually. In terms, because you talked about ultimately targeted interventions, especially by the government for poor population, for marginalized population. And I think similar approach we also have taken in India. I would have liked to learn a little more about some of other efforts which the government of Indonesia has taken over, probably to address the COVID issues, like some that Soumya talked about, how the food security schemes in India have helped sustain poor families in the pandemic times to overcome food crisis because of the loss of job or because of the marginalized income. One aspect I thought, if there were some of such actions from the government of India, maybe we would like to learn about it. Likewise, I would also like to learn about if there were any cash incentives, as Soumya also talked about, for Indian particularly. So maybe it would be more useful to have a little more understanding on them. And would be probably useful to have some comparative analysis of approaches adopted in Indonesia vis-a-vis some other countries in Asia, for example. That's another thing that I thought would be useful. I was not surprised to see the way your Google Mobility Index behaved actually. It was very much on the expected lines. For example, you would expect no change in mobility related to daily needs because people have to have those. But certainly you expect much deeper decline in mobility with respect to, for example, entertainment or going to a transit place, etc. Because of the closures and all that, the entertainment places are not available, so people don't really go there. Or even the malls were closed, so shopping is relatively less. So those were very much on the expected lines. So that's about you. Now, beside this, I was wondering whether this is it about consequences of COVID pandemic on the population. Why is it that we have not considered our child population, specifically how their lives have been affected by this COVID pandemic? Likewise, our elderly population. And I'll give a couple of examples as to why I think that's important for me. Now, I was just thinking the whole concept of online classes. Now, a 3-year-old child, make him or her sit on a fixed place against the screen for half an hour, 45 minutes. It's a hell of a punishment for the parent. You don't expect a 3-year-old child to be as disciplined. Child doesn't know what is happening around. And what are the implications of then these exposures on our children? We don't really know anything about that. Likewise, to be able to expect too much out of this 2 or 3 or 4 or 5-year-old child through the online mode, which is the expectations of the teachers as they do as a part of their normal teaching, is not going to help any child. Children are not learning. It's the parents who are learning actually, because they are the one doing the work for child. Child is doing nothing. All the homework that is given in the name of child is actually being attended by the parents, and mostly by mother, not even father, if I could add that in terms of gendered aspect of it. So I think we need to look have
Dr.
some
Usha.
Yes, please. And just last
I think yeah.
Yeah. So, and likewise, we don't know what is happening to the lives of elderly people because of the pandemic. They probably are the biggest sufferers then, and we know nothing about them. So I'll end with that then. Thank you very much.
Thank you so much, Usha, for doing a synthesis of all the 4 presentations so wonderfully and raising some new issues as well. I'm sorry that we don't have really the time for any questions, and unless the organizers give me a little more time, but I am told that there is a concluding session. Is that right, Saeed? If Saeed is there.
Yes, we are going to have a validity session now.
Take 5 minutes.
Okay, but you can take 5 minutes time.
Okay, so there is one question which I can see, who I'm not going to say to whom it is, or I think it is to Shiri. Just a second, let me just read out the question. Are there new opportunities for adolescent programming that emerged during this pandemic? I think it's to Shireen.
Yeah. Oh, you want me to
Shireen.
respond?
If you would like to, just very quickly and
no. Very quickly. I think my last slide tried to elaborate some of the points that I thought had emerged. But maybe the person who wrote it can write to me and we can discuss further. Thanks.
Yeah, because there's one question with not to any particular presenter, but it says, how did the lack of mobility affect food security for families, and was there a gender dimension to it? So perhaps this is for Soumya, or maybe to more than one presenter. And I think it would be important for us to note down these questions rather than respond to them, each one of them, because of lack of time. But I also see one question which talks about, are there some studies on mental health of children in child marriages? That is, those who have been trapped in child marriages, are there particular studies to look into the mental health issues?
I think that question was for me.
Yes.
So shall I quickly answer it?
Yeah, please.
You know, I haven't looked very carefully at these data, but the Udaya study by the POP Council in UP and Bihar, that was pre-pandemic, and the Dasra similar study in Jharkhand have shown differences in mental health. Of course, it's higher among the married than the unmarried. And as maybe Soumya knows, the POP Council's work, Santya would be the best person, has done something during COVID times on mental health, but I'm not sure whether she separated married and unmarried girls.
Yeah. Okay, so I would just take maybe 30 seconds just to sum up. I think, you know, the presenters have brought forth the point that most of the problems are, you know, known. There are these problems already in our societies. But what is very important to note that most of these problems have got accentuated further, and many more people have come under their ambit than was the case pre-pandemic. So more people have got impoverished, more people have lost jobs, more people have, you know, become hungry and so on. And the gender divide has got really accentuated across domains, whether it was Shireen's presentation or Soumya's presentation. And also, I think, and of course, very importantly, that Ravi showed the importance of tracking data segregated by sex. And the importance of doing this across globally, because otherwise it's such an imbalanced picture that we are getting. Two things which I think are very important, which this particular pandemic and the data that we are collecting has told us, is that there are some new forms of disparities and new forms of disturbances which have appeared. Cyberbullying, for example, you know, the more we go onto digital platforms, the more we are seeing cyberbullying happening, and a very important acknowledgement that has now been given to mental health as an issue across board. I think there was so much, you know, that we were lacking all the time. Mental health has not been taken up so seriously by governments, but in the COVID times, they have realized that we need to take and invest in mental health of people. I think this whole pandemic has reinforced the importance of understanding the intersectionality of impacts and thereby the need to mount multi-sectoral response to the pandemic. And this was a point made across all the 4 presentations. And there is, I think, every bit of work that we have to do in terms of data collection and continuing on our social science research. So thank you very much. I really enjoyed listening to all the presenters and learned so much more. Over to you, Saeed, for your
thank you, Professor Charlie Bharat, and all the panelists. It is pleasure listening to you and listening about other countries, not only India, Kenya, Indonesia. We have learned so much about those things, as well as it was quite interesting to see the gender, data on gender. And we had also one-day workshop with Professor Verma. On that day also, we were discussing why this data is not available. And when we talk to medical people and other people, they say that it's not required. It is not required. It is difficult to keep in our record so much. So that was quite interesting thing, and we can have many more issues which we can discuss in small webinars, which have been highlighted by the presenters as well as discuss it. We can take it up in future webinars. Thank you very much, all the persons. Thank you very much. Thank you, Iris, for joining us. Soumya, Shireen, Dr. Verma, thank you very much.
Thank you. Thank you.